So as you know, posterolateral tibial plateau fractures is a little dangerous zone for orthopedic surgeons to approach, but then at the end of this, I expect that we should have some clear ideas. The importance of this is at the end we should be at least come to a conclusion which approach to use when. I am going to talk about this particular portion, that is the posterolateral tibial plateau fractures. The importance of this is if you don't treat them, they end up with a flexion instability. And one important message I would like to give is you are most likely to miss these fractures unless you do a CT scan. So we are going to see this is the list of various ways in which you can approach the tibial plateau. The first important is direct posterolateral approach. Then this is a major workhorse actually, that is an extended anterolateral. It is also called suprafibular approach. It is also called para-FCL approach. Then if the posterolateral fracture is extending medially, that is medial part of posterolateral fracture, or if the apex is quite distal, then you can indirectly buttress it with an reverse oblique plate with a medial, posteromedial approach, which probably almost everyone is familiar with. Then we will see about the Frosch. Then the posterolateral, I haven't done the fibular neck or head osteotomy, and it is most of them have given it up. Sometimes a lateral epicondylar osteotomy also can be done, but I have no experience with that. So we will see about now. This is a case which I did when I wasn't aware of a Frosch approach. So this was the plain X-ray of the patient. You can see that there is a anterolateral element as well as a posterolateral element. So in this particular case, I address it with a posterolateral and anterolateral approach separately. So regarding the posterolateral approach, the incision is parallel to the fibula, and a transverse incision helps you in better retraction. So that's the lateral gastrocnemius. The key is you should palpate the biceps femoris first. So that is almost always palpable, and just posterior to it is the common peroneal. So you isolate it properly. Don't take a bold incision. If you take a incision like an orthopedic surgeon, you will cut it. So that's the only thing. Then lateral gastrocnemius and soleus you will separate. So a bit about the vascular anatomy, we will see that here. So this is the popliteus and this is the soleus. So soleus originates from the tibial soleal line as well as it originates from the fibula. So what you need to do is once you retract the lateral head of gastrocnemius, you will see the popliteus and the soleus also. So you will cut the fibular origin of soleus distally, and as you keep on doing that, you will underneath are the, you will come to know the, you will come across the inferior lateral genicular artery, and if you inadvertently try to go further down, you will come across the anterior tibial artery, which originates from the popliteal and goes in, crosses the, pierces the interosseous membrane and goes anteriorly. So that is the limitation. So medially you are limited by the popliteal vessels, laterally fibular head, distally the anterior tibial artery origin, and obviously proximally the joint. So minimal access is there, and you have to work into depth. So in this particular patient, which I did in a lateral position, so that's the common peroneal, that's the sural nerve, this is the lateral gastroc, this is the soleus which has been reflected distally, inferior genicular artery being tied, and this was fixed with a small buttress plate. Generally, 2.7 distal radius plate only fits. Sometimes, if you find that the space is less, you can get away with CC screws with washers. So this was fixed like that, and that video चालतो का नाही रे? चालत नाही आहे यार, काय होतो का रन तिथून, because that's a video actually which shows proper elevation, hey, proper function, but there are other two videos which show, forget about it. Then होते का फक्त पुढच्या याला बघ. हां, so we'll come to the Frosch approach. So Frosch is exactly the same thing which I did, except that the incision is one. So the incision is parallel to the fibula, and the same surgical windows are there. Posteriorly, whatever I talked, and anteriorly, just anterior to the, so that's the X-ray of the patient. So unless you see, you do a CT scan, you will not come to know about the complexity of this particular injury. So that's the anterolateral part, and you can see that this is the posterior, the posterolateral part. So this was managed again with a Frosch approach. So that's the biceps femoris, this is the common peroneal, this is the lateral gastroc, and then we ligated the inferior genicular branch. Then we go anterior. Simultaneously, you go anterior to the IT band. You do a submeniscal arthrotomy. These are the meniscal tagging sutures, and then you. Now, in this particular patient, it was difficult to pass or put a plate. So what was there was the space was really less. So I used 2 CC screws, and this is the outcome of the patient. Now, very important approach is the suprafibular approach. So this is para-apsial approach. Here, what we utilize is the space between the tibia and the fibular collateral ligament above the fibular head. So there is a distinct space there. The patient is positioned in a lateral position. It is nothing but an extended anterolateral approach. Only thing is proximally it extends posteriorly above the fibular head, and there you need to, if you keep a bolster in the distal thigh region, that helps to give varus, and you can peep in the joint very easily. And then you have to beware that you will not cut the fibular collateral ligament. So beware of it. If you give a varus force, you can actually palpate it, and then you can isolate it. So in this part, I am not going to talk about the medial fixation which was required in this particular case. So you can visualize that when there is a posterolateral depression major, so this approach is extremely useful. After elevating it through the anterior window, because through the anterior window you elevate it. This is a subchondral screw which has been passed after elevation. A small plate, like a rim plate or a hugging plate. Now this is actually a video. Because it beautifully shows. At the end you will run, or so that was the video of the first patient. Can you run this one? So here we have created a window in the anterior cortex, and otherwise I will go, and at the end we will show you these videos. Because I actually checked it there, it ran there, but now it is not showing. Now, so that's the screw which has been passed as a rough screw. This is the medial fixation, the posteromedial fixation, and this is the plate. And you can see that we did a post-op CT to confirm about the fixation. So that is the posterolateral which has been elevated. That is his function. Now again, this is a similar case wherein you can notice that the depression is too much, and a suprafibular approach is a wonderful approach. This also is a video. I will go, and then they will show us the video. So that is the outcome. So the take home is, if you need to buttress the posterolateral fragment from behind, use a direct posterolateral approach. If it is mainly the depressed and you don't need to buttress the posterior element and you need only to elevate, use a suprafibular or para-apsial approach. If the apex of the posterolateral fragment is extending down the very down, then you can indirectly buttress it with a reverse L approach, that is the reverse L approach, which is used for posteromedial fractures. And if you are required to tackle the anterolateral as well as the posterolateral fragments, Frosch is the best approach.
So time.
Thank you.
We will play the video.
So that's the video which shows that there is anterior window, and you can see that it is elevated properly. Then you, whatever is the void, you put allograft there, which is readily available with us also. You can see that it is being elevated. Thank you.